Okay, so one of the major problems you'd say is that kids are having side effects. So maybe not just polypharmacy, but in fact we're seeing kids porking out or having metabolic syndrome or a new wave of diabetes or at least future diabetes because a bunch of kids, a certain number now, are putting on 20 pounds. Okay, so that's a very, very important issue. And I'm sure it's going to get worse before it gets better. Yeah?
This kind of goes back with the whole polypharmacy. I find that one of the biggest challenges is that people like to add, nobody likes to subtract.
Absolutely.
And they get nervous.
Absolutely.
I picked up a kid at the Deaf Academy with CMV exposure and congenital deafness, was on 5 antipsychotics. 5.
No justification for that.
Amazing. She said no justification.
Well, there was no justification, and the kid had a liver out to here. So the issue was, and he was on 2 mood stabilizers, and then he was on a little bit of Adderall because God knows he couldn't stay awake during the day. So the issue for him was that it's not, and I think for a lot of kids is that let's pick from column A, let's pick from column B, let's pick from column C. That one's not, I'm not sure what's not working, so let's add another one from column A. Nobody subtracts. And so, you know, when I first picked up that kid, I sat with the parents and I said, he's coming off meds, okay? We'll do them one at a time, but he's coming off. There's no way.
Okay, but it's Stephanie, right?
No.
Oh, that's Stephanie. Karen?
It's Karen.
It's Karen. I'm getting, oh, everybody at this table. That's cool. Karen. Okay, but when we talk about putting them on, we can't get them off. Let's think, that's a very interesting problem because it's ubiquitous. How would we describe that problem in terms of what would have to be different to get over that problem? Like, what's the quality problem there?
What's the what problem?
The quality problem. If there was something we could fix, how would we do it?
As far as the quality of it?
So in other words, we could argue, hey, once a kid gets one of these meds, everybody's scared from that point forward, and the kid just stays on them, and everybody keeps renewing it.
Right.
And very unusual. None of these kids ever get fewer, so to speak. So that's a problem because you could argue right in the face of it, some kids should be getting better, and they have bad patches, and we should be taping them off. So, and guidelines say don't keep these kids on it forever. So, how do we reframe that problem?
That quality problem you're talking about, I think John had mentioned, for kids who are state dependents, there is you said it was a 9-page form. It's actually a 13-page form that we need to fill in to request medication. Right. The form is supposed to go to the court, and the court order is supposed to be issued within 3 days. In reality, it could take, I know we've had one that sat for 7 months before we got approval on it. And so the thought is that when you're requesting medications, you better request everything that you could possibly think to use.
Is this kids in foster care or inpatient, SIPPs?
Yeah, but the thing is that foster care
I don't start them on
you have to request just the one that you want to use that moment, and
but,
that
I mean,
take forever.
Imagine that every time I want to change the medication, I have to wait another seven months. That means that I'm going to actually request several medications at a time. I'm going to be pretty darn afraid to take them off medications. I mean, I tried.
But you wouldn't start them all. You request 3 just in case you're not going to start all 3.
I cannot do that.
I wouldn't start them all.
But so, well, what's the problem there from a quality perspective if a kid goes on a med and never comes off?
Well,
what's missing?
Education.
It isn't some way of assessing whether it's good enough now, right? I mean, going back to what John was saying, isn't there an assessment problem here? How do we know it's been long enough? So that feels like an assessment problem.
The monitoring.
Yeah, okay.
The other problem you have is as you taper down, sometimes the behaviors are going to go up for a while.
Right.
And the staff or the parents or whoever is got to be able to, no tolerance for that. And so you've got to somehow convince them that they're going to have to live through this, and you have to convince your staff and the administration and the parents that, you know, Johnny's going to get a little bit worse here for a few days
before he gets better,
and maybe even he'll have, you know, some dyskinetic movements if we're taking him off something that, you know, and it's not that you know, he has to go back, or it's not the new medicine we're at, and it's the old medicine.
But what you're really talking about is informed consent, and if we did a better job of that in the first place, we might have more buy-in.
So
You
kind
know,
of letting the parents
yeah,
know. And,
exactly. I mean, staff are always going to give you a hard time. That's their job. They're going to say, Doc, you need to fix it, but you're
you
the
might
expert.
inform them, they still don't want, not always inpatient, but that
I
outpatient.
know.
The kid starts acting out,
Exactly.
and they want you to do something.
No,
And they
I
want you to
know.
put them back on that med.
okay, so so let's just kind of go over what we want to is identify problems that you're facing. And now as we do that, I want to just ask you one thing. Are there some problems that are really more, not so much in the SIPPs or statewide, or are they always the same problems? You have problems with polypharmacy the same way it's polypharm in the state. It's adding more meds, same in the state. I mean, is it the same general problems? Anything different about the kinds of problems you encounter in the SIPPs versus in, say, prescribing in the state?
I think the expectation of the psychology is the team. You know, they expect you to start a medication that work immediately. So they get desperate, they call every day, so we need to educate that doesn't work like that. And there are some behaviors that are not going to change with medication because they call you, and that just the anxiety of that made you to use more medication, change it faster than you're supposed to, and all that with this is the team, the one that made the pressure sometimes. They need to be educated more about it.
Does that happen more in the SIPPs or in general outpatient practice?
More in SIPP because
In the
in
inpatient setting.
yes, because the outpatient and the crisis, because I have the crisis unit too and the inpatient unit, and that is because it's shorter. The time is less, but in the SIPP, because
They have to live with
every
those
day.
kids, yeah. Lisa, could you write up our big obstacles on that? So the first one was polypharmacy. Second one was the assessment challenges. So, so we had the polypharm, the assessment issues, always continuing to add, the difficulties getting under assessment, the difficulties getting a real extensive history, really ferreting out what's going on historically, developmentally. Always adding, never taking away. Education of families, and pressure to prescribe. That's what we've heard so far. So the question is, what are there efforts that have been taking place thus far that seem to be working on this problem? So you showed data last night that you've been working on this through academic, at state level, academic detailing, a number of other things, trying to get some of the prescribing practices that seem to be pretty far out there, kind of pull them in a bit. So if you look at those problems, what else have you all been doing, either personally or in your unit or statewide, to address those problems? So, so what I want to know is, so John, take that. Have you found some ways to educate staff that really say this made a difference? In other words, that when you went in, you worked, say, with your inpatient staff or whatever, it was this way when I got my hands up to my elbows in this place, then I had to do the following, and now it's this way. So that's what I'm looking for. What have you tried?
Well, mainly through in-service training with the techs and through treatment team, informal communication.
Oh, interesting.
With the treatment team.
Okay, so in-service training now of course we spent the morning talking about the therapies, interesting milieu stuff. And so when we think of the psychopharm problems, which in-services will you say, yeah, this is going to be getting at that area, John?
No, I may have a tech say this patient needs to be on more medication because he's agitated, nervous, threatening behavior.
Yeah.
And you really have to sit down with some one-to-one and tell them the limitations of medication and advantages of talking to the patient.
It's not a magic bullet. Who else has done things, they say, this is making a difference to address some of those problems?
I also, as the director of nursing, I understand what our doctor, if we have one doctor, what his prescribing patterns are in general. On orientation, I do a whole orientation section just for medication, for the caseworkers, for the therapists, for the nurses, for the direct care staff. And I give scenarios of kids that we have currently, so right when they get to the floor, they understand why kids are on certain medications.
Uh-huh. Who's doing, does anybody have things that got counting programs going on? Yeah.
Yeah. 3 years ago when I started, we had 75 seclusion restraint incidents a month with an average daily census of 67. Now our average daily census is 88, and we had 17 last month.
Fantastic.
That's fantastic, that's awesome.
Okay, that's cool. That's really good. So who else is counting stuff and finding that?
You know, you were talking about how do you go about changing the mindset.
Mm-hmm.
And so sometimes when staff come to me and say, I think you need to put this patient on a stimulant medication.
Can you hear?
So what I'll do is I will say, okay, I want you to document. So I'll give them forms and I will say, I want you to document his behavior for the next week, and we will meet a treatment team and we'll go over it and see how he is.
Whoa, that's good.
So,
what forms do you give them?
Like an ADHD checklist,
Okay.
or child behavior checklist.
Now,
whatever I think
do
would
you
be
just do that on your own? I mean, that's pretty cool, but I mean, the unit doesn't have something it would normally use, so you have to.
They have. I will just tell them do this checklist.
You really?
When I tell them, they
You
know.
personalize it in a way.
So yeah, it depends on the patient.
Very
And
interesting.
sometimes
Very
even
nice.
the parent will call and
Works
say,
with families.
yeah,
Yes.
they'll call and say to me, oh,
Yeah.
I think you need to put my son on ADHD medication or this medication. So then I will say, okay, I want you to tell me why, and describe to me what the behaviors are, and then I'll give them some more checklists and something to do.
All these kids that are dependent children should have had a comprehensive behavioral health assessment, and all that information should be in there. If you guys aren't getting it, we need to know that.
Not
We
the
did not,
medication.
if it's coming from specific places,
Somebody's violating.
But we need data.
Somebody's violating some
Yeah, we
statutes,
need
basically.
data.
So I would
Yeah.
think if people are saying there's a problem and the state is not getting that data,
Right.
part
We
of
can't
us,
fix what
we
we
are
don't
not
know is
doing
broken.
our jobs
Exactly.
partly. Okay, so that's
Yeah.
very interesting. When
So-
I have incomplete information, and I just say, dang it, more incomplete
Right.
information
Right.
from the same place,
Well.
and I don't tell the
yes,
state.
Exactly. That, and also your admissions people. I mean, you have a certain list of information you're supposed to get. If admissions is saying, we'll take that patient even though we don't have the information, that's their bad. And you guys need to be giving your CEOs information about that and say, this is not acceptable. It's, it's compromising patient care because we don't have good information. So, don't be silent about that. Be effective and talk to the people. that need to
What
fix
Jane
it.
has just kind of identified is when we get these things, it's another great example from this morning, there's something I could begin to make a difference on. I can do something
Right.
about. It may take a while, but
Yeah, it does
as
take
long
time.
as I say this is acceptable by passive behavior, it's an issue. Okay, so I'm hearing some ideas. I don't hear very much. I hear a few ideas, but it seems to me, guys, your quiver's pretty empty.
There's a lot of things we count. We count days lost. See, you have to earn so many points to get a day. And to get a day, that counts toward going up your level system. So it's very easy to keep track of days lost.
Oh, you mean where they don't move?
They don't move.
Oh, clever. Great idea.
You can also look at early consequences in terms of early beds.
Bedtime, yeah, early bedtime. But see, what's interesting is that ties right back into what Lisa was talking about this morning. So you could see kind of, if you're using a behavioral program, very, very interesting. And it would be interesting to have it charted where other kids can see it, kind of publicly.
And each kid has their own chart in their record.
At Boys Town, we were talking about earlier, but they carry a little tag on themselves. And so then that gets kind of recorded at the end of the day. I mean, they do it really fancily for every half hour or 20 minutes or something. But the kid carries a tag, and then so they actually know all the issues that went on for the day where it's carefully counted. And it's so interesting because you can just see. You can see when a kid had a visit from the dad he did not want to see, who was the mean abusive stepfather or something like that, or where medicine was changed. Just very, very interesting. So you can actually begin to, now what's interesting about that, does that sound interesting in terms of helping us know about the effect of always adding and never taking away?